Hi all, we are the AHCA Internal Medicine Chief Residents, and we will be discussing the Affordable Care Act with you over the next hour or so, hoping to help navigate the recent discourse about this. We have no financial conflicts of interest to report. Perhaps the most controversial act to pass through Congress in recent past was the Affordable Care Act, and it has enraptured the popular news media and Washington since its birth. Most accept that the ACA has flaws in its present form, but the question remains whether subsequent legislation should work to repair the Act or replace it. Our objectives are to present an overview of the ACA and examine its impact on Oregon, then outline current problems in our healthcare system, and then finish with potential solutions, including a brief description of the AHCA. I'll begin with a broad exposition into the U.S. healthcare system, followed by a description of how the ACA influenced that system. Bear with me here, I'm going to build a somewhat complex picture of our current healthcare system. When Calvin gets sick, the earliest payment system in the U.S. for his condition to be treated was self-pay, where he provided money and healthcare provided buildings and people with skills in the forms of goods and services to treat his illness. As medical technology and subsequent cost advanced, insurance companies came about to blunt this cost. Their job was to pool premiums from insurance holders to share the risk of an illness, such that payment for those same goods and services was less, in the form of a copay. Company doctors working under rail and coal companies came about in the 19th century and were the precursor to employer-provided health insurance. Under this model, the employer diverted part of the employee's salary to buy insurance. The system was nice for those with money or a stable good job, but as the Great Depression made poverty more widespread, public options seemed necessary. FDR's Social Security Act of 1935 was the first gesture in this direction. In 1965, with only 60% of those over the age of 65 with any health insurance, Lyndon Johnson signed the bill for Medicare, an addendum to the Social Security Act. Medicare initially covered those over 65 and the disabled population. Those with ESRD and ALS were added later. A second amendment to the Social Security Act occurred in 1965 as well, Medicaid, for children and the poor, which was a partnership between states and the federal government. The four parts of our system, 1. Self-pay, 2. Private insurance, 3. Employer-provided insurance, and 4. Public insurance, comprise our current healthcare system. So how does this stack up? Let's first back up slightly to introduce one of Calvin's favorite shapes, the triangle, specifically Kissack's iron triangle. Dr. William Kissack devised this framework for understanding healthcare systems in 1994 to emphasize the interdependence of all three parts. Let's review each aspect in the U.S. healthcare system. Access to our system has grown over the years but remains poor. As of 2010, before the ACA, 16.3% of the population was completely uninsured, which included those who could and could not afford healthcare. According to countries with primarily public healthcare systems, this is low access. Quality remains a difficult variable to approximate, but worldwide studies using surrogate measures of quality all conclude that healthcare in the U.S. isn't high quality. We're 34th from the top for life expectancy. We have infant mortality rates that are 2 to 3 times that of top countries like Japan and Sweden, and we're the most obese of all the developed countries with an average American BMI in the low 30s. Finally, cost of our healthcare system is arguably the most eyebrow-raising of the entire enterprise. Each dollar here represents average spending in developed countries, and we spend 2.5 times that, or 17% of our GDP. Most other developed countries with reasonable healthcare systems spend 8 to 12%. The ACA is a recent response to some of these problems and was signed by Barack Obama on March 23, 2010, with most provisions having an effective start date of January 1, 2014. The full write-up of the Affordable Care Act is around 2,400 pages, with 10 major components or titles. It's big and complex, just like our current system. I will certainly not cover all components, but will focus on 2 broad efforts of the Act, which are arguably the most important. First, expanding access. The ACA is a recent response to emphasize let's make Kelvin grow up a bit first to emphasize that we're discussing the next phase of our system, the Affordable Care Act. All right, the ACA expands access in multiple domains, but we'll start with the private insurance part. It all starts with the individual mandate. Most Americans are required health insurance aside from three groups. One, those with employer or public provided insurance already. Two, those undergoing financial hardship, which is quite broadly defined. Or three, those in a recognized religious sect, which is mostly Amish. Those who did not satisfy the mandate are charged an annual tax whose amount escalated through 2016 to around $2,000 per family. A second effort to expand access in the private insurance arm are health insurance exchanges. The exchanges are meant to partially balance the mandate by offering a centralized online location for private insurance. Insurance carriers submit their plans to the state and they approve that plan. These plans are then displayed on a website meant for consumers to browse. And all of this is to improve user friendliness. Finally, a third effort is known as subsidies. The federal government financially supported some plans purchased through the exchange if you're poor in three ways. One, there is an annual cap on your premium. Two, the feds will boost your plan to cover your copays, etc. And three, there is a graded limit on total annual out-of-pocket costs. For example, if you make just over the federal poverty limit, your premiums annually are capped at 2% of your total income, your copays are lower, and your total out-of-pocket costs are capped at $2,000 or $4,000 depending on household size. Let's move to expansion efforts in the employer-provided arm. This section is brief. Basically, after the ACA, all large employers, which is anybody over 50 full-time employees, were mandated to offer some form of health insurance to their full-time employees, and it has to be reasonable coverage, otherwise they have a tax penalty. Finally, let's move to expansion efforts in the public sector, which is primarily the Medicaid expansion. Medicaid eligibility is key to the Medicaid expansion. About 1 year before the ACA was enacted, there was wide variability in eligibility criteria from state to state. 16 states on this figure restricted Medicaid access to those with an income less than 50% of the federal poverty line, a value less than $10,000 per year, which is pretty darn restrictive. The Medicaid expansion set a national standard for Medicaid enrollment eligibility to 138% of the federal poverty line for all potential patients. For this expansion eligibility, Medicaid would see an anticipated 10 to 15 million new enrollees, and the cost of this boom would be on the federal government's shoulders 100% initially, tapering to 90% by 2020. Initially, the expansion was expected to roll out nationwide, but after a Supreme Court ruling in 2012, it was curtailed such that states could opt out. 34 states opted to implement the expansion, and 19 states kept their previous systems without expansion, opting out. So to summarize, eligibility would increase substantially. The federal government would pay more to Medicaid to offset the larger cost of healthcare as a result. So the ACA addresses access by expanding private, public, employer-provided, and public coverage through a combination of subsidies, eligibility expansions, and coverage mandates. All of this ideally would expand access to care, but practically speaking would increase the number of healthy patients in the pool of those covered, thereby improving the ratio of premiums paid to insurance claims paid. Getting back to the major points of the ACA, however, let's move on to the consumer insurance protections. To protect consumers from empty plans, the ACA mandated all insurance policies cover 10 essential health benefits shown here. While these might seem a matter of course, many Americans who purchased health insurance before the ACA bought plans that were ridiculously cheap that offered nearly zero benefit, such that many had insurance but many were still underinsured. Finally, insurance companies were no longer allowed to block coverage to patients with certain pre-existing conditions. Some estimates place 50% of Americans as having a pre-existing condition that would lead to insurance coverage denial by most major insurance companies prior to the ACA. Putting this together, yes, the ACA was a way to expand coverage of care, but it did so in a way which ideally increased the number of folks in the market that weren't terribly sick and tried to keep those folks well and out of the hospital by expanding coverage for ambulatory care, such that the overall provision of insurance was greater, but this did not necessarily lead to higher usage of costly tests or interventions. Thank you. I'll next hand this over to Dr. Katie Thilo to discuss ACA's impact on Oregon.
Thank you, Dr. Ehler. Next, I will discuss the impact that the ACA has had on our state. Prior to the ACA, Oregon struggled with a high uninsured rate of about 17%. Now, our uninsured rate has impressively decreased to only 5%. This figure illustrates the Medicaid and tax credit eligibility of Oregonians based on income. Those with incomes under 138% of the federal poverty line are eligible for Medicaid, or as we may be more familiar calling it, Oregon Health Plan. After the Affordable Care Act passed, the state accepted the federal government's Medicaid expansion to fund this. Since the ACA, about 400,000 more people have enrolled in Medicaid or OHP. Those above the 138% federal poverty line can purchase insurance on the exchange or marketplace. If they are below 400% of the federal poverty line, they are eligible for tax credits or subsidies to offset costs. Oregon experienced a bumpy road in creating their own exchange or marketplace, Cover Oregon. You probably remember at least one of two things about Cover Oregon, either the epically expensive website failure or their adorable commercials. Ultimately, Cover Oregon was abandoned, and Oregon elected to use the federal government's website, healthcare.gov, as the marketplace of choice. Though their commercials aren't as cute, the website works, and 106,000 people have gained insurance through the marketplace with tax credits or subsidies, and another 49,000 obtained insurance on the marketplace without subsidies. This is a lot of newly insured people. Oregon has been identified as a state that devoted significant resources to this expansion. For example, the state mailed 300,000 notifications to Oregonians eligible for OHP with a simple sign-up process, and also offered a fast-tracked process for those with prior Medicaid enrollment in the United States. This rapid increase in the insured population ranked to be the third highest percentage growth in the country, behind only Kentucky and Nevada. Next, I will speak on the many economic changes identified since the implementation of the ACA, one of which was job creation. In a 3-year period during the implementation of the ACA, over 20,000 new healthcare jobs were created in Oregon, 4,000 of which were at OHSU. The state budget significantly improved with the federal funding provided for the Medicaid expansion, though this roughly comes to about $2 billion per year. Oregon was a state that had been using its own state budget for its own Medicaid expansion prior to the ACA, so accepting this federal funding was an easy decision by Oregon politicians. With more Oregonians insured, there is more financial security among individuals. In fact, the Oregon Food Bank noted that their needs dropped in half between 2012 and 2015, and that fewer Oregonians report health care as a major reason that they need food assistance. We even have quality evidence to support the fact that Medicaid expansion provides financial security. Our state has been made famous in the world of healthcare reform through the Oregon experiment. It subjected a Medicaid expansion to the rigor of the scientific method through an innovative, high-quality, randomized controlled study that aimed to evaluate the impact of Medicaid in the United States in 2008. Though this was pre-ACA, it investigated the effects of the Medicaid expansion on financial and clinical outcomes. It showed that the Medicaid coverage generated no significant improvements in physical health outcomes in the first 2 years, though it did find a significant reduction in financial strain. This table from the publication demonstrates how the insured population had significantly less healthcare out-of-pocket spending and were less likely to borrow money to pay bills or have a skipped payment. This may not be so surprising, considering that any other type of insurance you purchase, auto insurance, life insurance, renter's insurance, aim to provide financial security in the face of potentially unanticipated spending. So say Calvin is uninsured, gets sick, and seeks health care that he cannot pay for. Then what? Well, hospitals frequently front these bills. The coverage expansion has saved Oregon hospitals millions in uncompensated care costs, dropping by over $500 million over a 2 year period. With the plummet of these charity care costs, hospital revenue has boomed. This slide comes from OHSU's Board of Directors meeting, which demonstrates the impact of the ACA on Oregon hospital earnings. The red line shows the patient census remaining constant, while the blue line demonstrates the rising revenue. This rise in compensation to hospitals is being paid partially by the federal Medicaid dollars as well as by insurance companies. This brings us to one negative economic outcome that I'd like to discuss, which is how insurance companies are losing money. Insurance companies have been struggling to make money in this new market, and thus Oregonians who participated in the new individual market saw their rates climb an average of 27% in 2016. For customers facing these rising premiums, it offered the difficult decision to purchase unaffordable health care versus tax penalties. So why such an aggressive increase in rates? Insurance companies argued that it was either this or they go out of business. When the marketplace opened to customers with pre-existing conditions, these new expensive customers took a toll on some insurers' bottom lines. These insurance companies had been incentivized to offer competitive rates on the marketplace with the promise of assistance by the federal government to offset these anticipated costs in the early years through a temporary risk corridor program. However, this program ultimately did not pay out as promised, leaving insurance companies in debt. MOTA, for example, would have expected $179 million from this program and has only received $11 million as of late last year. Since 2014, Oregon insurers have cumulatively lost $264.4 million. Providence Health Plan posted the largest losses of $63 million in 2015, and MOTA had a near-death experience, though managed to survive by borrowing large sums of money from its parent company and from OHSU. Other companies did pull out of Oregon's marketplace, however, leaving 58,000 Oregonians to find other insurance back on the marketplace. So to summarize, the ACA has provided over 500,000 Oregonians with health care insurance, provided more jobs, improved our state budget, helped our poor and our hospitals, while placing financial strain on insurance companies. We will now transition to Dr. Kelly Littlefield, who will discuss current problems and threats to the ACA.
Thank you, Dr. Thilo. So now that we know some of the good that's been done and some of the effects of the ACA, let's take a deeper look at some of the current problems within our healthcare system, or the current threats to affordable care. I will divide this section roughly into two parts, the first being a discussion of the major issues facing our healthcare system, and the second being how recent executive orders by President Trump this January upon taking office may imperil some of the ACA's provisions that we have just heard about from Dr. Thilo and Dr. Ehler. I will start with a discussion of the major problems, noting that many of these predated the ACA, some of them were addressed by the ACA, and some of them were a product of the ACA. In my mind, repairing these issues will be key to ensuing healthcare legislation. You will recognize on this slide Kissack's triangle. This is from the introduction section by Dr. Ehler. As you can see, I've highlighted affordability and access, and these are going to be the two biggest issues facing our healthcare system that I will discuss. I will start with affordability. I mean this in a very broad way, for individuals, but also for the government and insurers. Currently, our American healthcare system works under the supposition that healthcare is a good in which the cost is greater than any of our individual ability to pay, which is unlike most any other good you regularly buy. So, some of us have employer-based insurance to help protect us from the financial ills of ill health. Some of us have Medicaid, Medicare, etc. You can see the breakdown here. About 57% of Americans are insured by their employer, here in the light blue. When you look at this diagram a bit more deeply, you will notice that the government subsidizes a little less than half of medical care. That is, Medicare in the teal section, Medicaid and CHIP in the bronze color, and the marketplace with the ACA in those two tiniest pieces at the bottom. I want to point out right away that the problems that have dominated the news and made reform seem so trouble, those soaring premiums and fleeing insurers, canceled policies, failed co-ops, and even the initial website fiasco haven't affected the vast majority of the public. The debate has focused almost exclusively on the hardships faced by less than 6% of Americans, those who have obtained insurance under the ACA's exchanges. I won't say this is an insignificant problem, since it affects nearly 23 million people, but I will say it is not our focus today. I will focus on issues that pertain to all Americans. Cost is a huge issue, and I think that most of us know that healthcare is expensive. But here you can see that the United States, the top line in this diagram, spends a larger share of its gross domestic product on healthcare than any other major industrialized country, and its rate of rise historically has been higher too. To give you a little more perspective, we spend nearly 3 times as much on healthcare as we do on education, and nearly 150% of education, military, and infrastructure combined. As you can see here in another representation, how the US compares to other countries in the industrialized world. The average amount of healthcare expenditure per capita is the red bar in the middle, and the US, on the far left, spends 2.5 times the average. Interestingly, here you can also see the dark bottom part of each bar is public spending, where the US is pretty near some other countries, but the private expenditure bar on top is overwhelmingly larger than other countries. That is the cost that insurers and individuals pay. But none of this translates into greater healthcare outcomes. In fact, as you can see in this chart, the US ranks last in pooled indicators of healthy lives, such as infant mortality, rates of diabetes, and other chronic illnesses. So why is this all so expensive? A few ideas are the following. We have a comparatively more liberal use of technology in our country. We have high costs at the end of life. We have less emphasis on preventative health care and, additionally, higher pharmaceutical costs. One last major issue is significant administrative costs. I'm now going to tell you a bit more detail about each of these factors. Application of technology in medicine seems ubiquitous and a cultural norm. However, the US uses technology much more than other countries with access to the same technology. Take, for example, MRI. We have nearly triple the number of units adjusted for population as the industrialized average, and we do 2 times as many exams, that second line. Another example is we perform nearly twice the number of knee replacements. These trends are also true for CT scans and other surgeries. Additionally, our average cost per intervention is significantly higher as well. Take, for example, angiography, $900 here and $35 in Canada. Hip replacements, $40,000 here and $7,000 in Spain. We also spend enormous amounts in the final period of life. In 2011, Medicare spending reached close to $554 billion, and of that, over a quarter, or $170 billion, was spent on patients' last 6 months of life. Not surprisingly to many of us, this significantly conflicts with many of our patients' stated wishes. In a 2012 survey of Medicare patients, over 3/4 said they preferred to be at home in their last days, did not want to be on a ventilator even if it added a month to their life, preferred comfort-promoting drugs even if they were life-shortening, and did not want to take potentially life-prolonging drugs if it made them feel worse. We also spend significantly less on social programs than other developed nations. You can see here that the US in the middle spends about 1/3 more than other countries on medical care, the bottom light blue bar, and the lowest of all of these countries on social programs, the dark blue bar on top, compared to other nations, reaching about half that of France, Sweden, Switzerland, and Germany. But what is the importance of social programs? Well, these programs, such as housing assistance, employment programs, disability benefits, and food security, end up accounting for about 40%, or the largest contribution of factors influencing health and well-being. Interestingly, medical care accounts for 10% of that. Next, we'll discuss some of the impact of pharmaceuticals on our healthcare costs. To frame this, I will tell you that in a recent analysis by the AHRQ, prescription medications now comprise an estimated 17% of overall personal healthcare services. Per capita, prescription drug spending in the United States exceeds that of all other countries, such that in 2013, per capita spending was $850 compared to an average of $400 for 19 other industrialized nations. One poignant example of this is the drug Harvoni for the treatment of chronic hepatitis C, costing nearly $100,000 per person treated. The most important factor that allows manufacturers to set high drug costs is monopoly rights awarded by FDA approval and by patents. In addition, another common point drug companies use to rationalize their drug prices is research and development costs, but evidence shows no association between these and drug prices. Rather, prescription drugs are priced in the United States primarily on the basis of what the market will bear. Finally, administrative costs have a significant impact on healthcare costs. This amounts to nearly 25% of every healthcare dollar spent and is the highest of 8 countries recently analyzed by Health Affairs. With time, costs, and personnel necessary to process billing and insurance-related things, significant redundancy and inefficiency arises in our healthcare administration. According to analysis by the Commonwealth Fund, the U.S. could save nearly $100 billion if it lowered administrative spending to the level of the Netherlands, who is the next highest spending country. To shed a little more light on this article in the New York Times a couple of years ago showed the salaries of hospital administrators and CEOs, which, as you can see, are far greater than doctors' salaries. And these figures do not even include bonuses or incentives, which can be much larger than their base salaries. Now let's talk about some of the costs specifically associated with the ACA. I'll say the most popular parts are the most expensive. That is, the clause preventing insurers from excluding patients with pre-existing conditions, and eliminating lifetime or annual coverage limits, or the amount an insurer can be asked to pay, cannot have any lifetime or annual maximum. However, the financial impact of those with pre-existing conditions is substantial. 20% of individuals account for 80% of healthcare spending, and the costliest 5% of non-Medicare beneficiaries account for nearly 50% of expenditures for the group. However, there has been broad bipartisan support for maintaining protections for pre-existing conditions. In his first interview after his presidential triumph, Trump told CBS News that he wanted to continue the provision that insurance companies could not deny coverage for patients with pre-existing conditions. And patients with pre-existing conditions were the most likely to get insurance with the ACA. This has led to what insurers call adverse selection, or consumers who are in most need of health care may be the more likely to purchase insurance. In other words, healthy people stay out of insurance pools and sick people stay in, particularly those who lack employer-sponsored insurance, Medicaid or Medicare. And as you can imagine, this group is the most costly. This has led, you will remember the individual mandate that Drew told you about. This was a mechanism that attempts to balance out this problem, including healthy people in the insurance pool to balance out the sick. Other terminology you may hear about this phenomenon is the death spiral, in which insurers are the most stable when healthy and sick people are in the same funding pool, so that as sick people draw from the pool, healthy people don't use it as often, the costs tend to balance out. When healthy people drop insurance, insurers pay out more than they get into their financial pool, leaving them with 3 choices. They can raise premiums, they can increase deductibles, or they can increase copays. Obviously, all of these make insurance more expensive, so healthy people are more likely to drop coverage, leading to more price increases and more people then dropping out. and the cycle goes on. In this figure, you can see how these adverse pools have affected the number of insurers throughout the country. Pre-ACA is the first column, and post-ACA are the other three, from 2014 to 2016. The dots on the far right-hand side reflect a net gain or loss of insurers, and all the red you are seeing is the net loss of insurers in many states. In fact, in 34 states, 75% of the insurance market is controlled by 5 or fewer companies. Most of us would agree that the market thrives when there is choice and competition, which is rapidly declining. From the example we just discussed, you can see how issues with affordability can translate into issues with access. And this is the next major issue we will discuss. One of the other parts of this issue is the number of Americans still without insurance, including those in states that did not undergo Medicaid expansion. As you will recall, 19 states did not undergo Medicaid expansion, here in the orange. And what is lesser known is that 7 states, those here with a tiny asterisks, have waivers in which they can cover adults up to 100% of the federal poverty level, but did not accept the ACA expansion up to 138%. The result of this is that nationally, we have millions of poor uninsured adults falling into what some call the coverage gap, meaning their income is above the historic Medicaid eligibility under 44%, here under the red part of the umbrella, but below the lower limit for the marketplace premium tax credits, above 100% in blue. Most people do not have access to employer-based coverage through a job in this coverage gap and have limited options available because of their income to purchase care on their own. Take the example of a 40-year-old non-smoking individual purchasing coverage through the marketplace who is in the coverage gap, so making around $10,000 a year. If he was at the bottom end of the coverage gap, purchasing healthcare would take about 50% of his income. If he were at the top end of the coverage gap, this coverage would cost about a quarter of his income. As you can imagine, this is untenable. Additionally, because this population is generally exempt from the individual mandate, and because firms will not face a penalty for these workers remaining uninsured, they will continue to fall between the cracks in the employer-based system. However, if states universally expanded Medicaid, 4.5 million Americans could become insured. Next, we'll discuss some of the threats to some of the provisions of the ACA based on President Trump's executive orders upon coming into office. That is, even without full Senate or congressional support of repeal of the ACA, as will be discussed in the next section in more detail, these executive orders have recently challenged some of our current healthcare system's foundation, possibly an attempt at facilitating an implosion, as you may have heard about in the news. In this perspective piece in the New England Journal recently, 2 lawyers, Stoltzfus and Lazarus, discuss President Trump's executive order, saying, "The order does not itself change existing regulations. Rather, it provides instructions as to how Trump wants responsible agencies to exercise their discretion in interpreting and applying statutory requirements." The priorities set out in this order were to waive, defer, grant exemptions from, or delay the implementation of any provision in order to minimize costs and regulatory burdens imposed on states, private entities, and individuals, to provide greater flexibility to states, and to encourage a free and open market in healthcare services and health insurance. The implications of this executive order are that federal agencies could stop enforcing ACA requirements. The IRS could stop collecting tax penalties for non-compliance with the individual mandate, although on February 15th, the IRS announced that it will enforce the individual mandate, but will not be beginning a new program to tighten up its enforcement. The government could stop requiring insurance companies to cover the ACA's essential benefits, rendering a quality issue to already an issue with access. And finally, the Department of Health and Human Services agency could also liberalize their authority to provide hardship exemptions, basically making the individual mandate meaningless. The result of this is that a precipitous change in the enforcement of the law could severely disrupt insurance markets with political and no less policy and humanitarian consequences. Mulling such prospects, the Congressional Budget Office projects that these changes would encourage comparatively healthy people to drop coverage, forcing insurers to raise premiums or withdraw from the markets altogether, which is another way of alluding to the death spiral. One final key element in negotiations for the future of the Affordable Care Act subsidies is the subsidies. Not funding these could also destabilize the healthcare system, even without repealing the ACA. Proponents say that not funding the subsidies would lead to a collapse of the exchange system, forcing millions to exist without affordable coverage. They also fear that even the prospect of uncertainty of these subsidies could spook insurers, who are periodically deciding whether to offer individual coverage for the following financial year. In summary, I want to point out that the threats to the current ACA state, from possible weakening of the individual mandate through lack of enforcement, to the eventuality of the subsidies, to any threat of protecting coverage for pre-existing conditions, are threats to the entire system as it currently functions. That is, these provisions are interrelated. Each of the main provisions of the ACA work together. The highly supported guaranteed issue, including pre-existing conditions, relies upon government subsidies and the individual mandate to make it more affordable. If we support the ethical premise that sick people deserve insurance and access to health care, which President Trump has agreed with, we must recognize the fundamental inseparability of the provision of the individual mandate and affordability. In other words, policies that do not address adverse selection will lead to an increased and unsustainable healthcare cost. And with that, I will turn it to Dr. Bailey Pope to discuss some of the solutions to our current healthcare predicaments.
Thank you, Dr. Littlefield. My colleagues have shown you just how complicated healthcare is. Now it's time to explore what the future of healthcare holds. We're going to break down the current repeal and the current repair options that are being debated in the Senate. The first thing we're going to talk about is the American Health Care Act. This, or the AHCA. This was introduced on March 20th and passed in the House on May 4th with two amendments, the Upton Amendment and the MacArthur Amendment. This bill is now in the Senate for review. When reviewing the bill, we will talk about it in terms of Kissack's triangle, using measures of affordability, access, and quality. We're going to first talk about affordability. On a macro level, the AHCA would result in a $119 billion decrease in the federal deficit. How does it do that? Well, it actually cuts $1.1 trillion of spending, much of that from Medicaid, and it gives a $1 trillion tax cut. This tax cut includes eliminating the tax penalty for large employers who don't provide health insurance, as well as the tax on tanning beds, health insurers, and pharmaceutical manufacturers, and that's just to name a few. Although on the federal level, spending would significantly decrease, much of that cost would then actually be shifted to the states. It is estimated that the AHCA would cost Oregon alone $2.6 billion over the next 10 years, if we were keeping up current coverage for our residents. When thinking about individual affordability, I'm going to actually talk about two counties in Oregon and compare what the premiums are for under the ACA and what the premiums are projected to be under the AHCA. We can see that for Oregon's most wealthy county, Clackamas County, with an average per capita income of $31,000, that young people, on average, would be paying about $2,480 under the ACA of out-of-pocket costs. If we look at the AHCA, those out-of-pocket costs would actually go down to $1,340. That's a total out-of-pocket change of $1,140. However, an older person in the same wealthy county would have a premium of $9,000, a credit of about $6,800 under the ACA, with a total out-of-pocket cost of $2,400. Under the AHCA, the premium would go up to $12,500, the credit would be $4,000, and their out-of-pocket cost would be $8,590. That is an increase in the total out-of-pocket cost of $6,110. Now, let's move on to our least wealthy county, Malheur County. A young person in Malheur County under the ACA would have a premium of about $5,600, a credit of about $4,700, and an out-of-pocket cost of about $960. Under the AHCA, the premium would go up to $5,200, the credit would be $2,000, and the out-of-pocket cost would be $3,200, thus increasing the out-of-pocket cost to this resident by $2,200. An older person in that same county would have a premium of $14,000 under the ACA, a credit of $13,000, and an out-of-pocket cost of about $960 under the ACA. However, if you look at the AHCA for the same person, the premium would go up to $19,000. The credit would stay the same at $4,000, and the out-of-pocket cost for this person would be $15,770. That's a total out-of-pocket increase in premiums of $14,810. If we take a step back, we can see that the AHCA increases premiums. If you keep the same quality of plan under the AHCA as compared to the ACA, the premium would increase by 13%. And most importantly, these increases disproportionately affect those who are older and poorer. Now let's move on to quality and talk about how the AHCA affects quality. So the first thing, within the MacArthur Amendment, states would be allowed to apply for waivers. One waiver would allow states to use health status as a rating factor for applicants in the individual market if their coverage lapses. Another waiver could reduce the essential benefits the states would require insurers to cover. It is estimated that about 30 million adults had a gap in coverage in 2016 and thus could be affected by the health status waiver. And it is estimated that about 27% of people on the individual market have pre-existing conditions that would affect the price and their ability to obtain coverage under this waiver. States could also apply. There are also a few changes to family planning, as this is no longer mandatory to cover, and also plans would exclude any abortion services. We're next going to talk about access. Prior to the AHCA being enacted, the uninsured rate peaked in 2009 at 18%. Under the ACA, this had dropped to 8.6% in 2016. However, with the implementation of the AHCA, it is projected to increase back to 18.6%. Thus, 23 million people who have insurance today would be uninsured by 2026. In Oregon, we are expected to have 465,000 people who would lose health care coverage based on the AHCA. This is an increase from the current uninsured rate of 5% back to 15%, matching pre-ACA uninsured rates. So let's reflect on the AHCA. When thinking about affordability, we can tell that it improves federal affordability by decreasing the federal deficit. However, these costs then shift to states, patients, and local communities. The AHCA does not improve access to care, and it does not improve quality of care. Next, we'll talk about the Chronic Care Act. This is a possible repair to the ACA. This act was presented for discussion in the Senate in May of 2017. It was created by with a bipartisan collaboration among senators on the Finance Committee, including our own Senator Wyden. Two of the senators who proposed the Chronic Care Act have also been asked to work on the work group that will be writing the Senate's response to the AHCA. The Chronic Care Act is narrow in its focus, as it only applies to Medicare. However, in the near future, we may see some of these ideas in the Chronic Care Act being applied to other sectors of healthcare. Medicare is not a small player in the healthcare realm. In 2015, there were a total of $540 billion spent on Medicare. That is 15% of the federal budget. And as you can see here, Medicare makes up 15% of all healthcare. So let's discuss the Chronic Care Act by looking at its ability to improve affordability, access, and quality. The Chronic Care Act has three main provisions that I'll focus on today. First, it allows more Medicare recipients to opt into ACOs. In addition, it increases the tools that the ACOs have to promote health. Second, it extends and expands the Independence at Home program, which is a home-based primary care program for Medicare recipients. And lastly, it expands the reimbursement for telehealth services. ACOs are similar to CCOs in Oregon. However, ACOs are reserved for Medicare patients, while CCOs in Oregon are reserved for Medicaid patients. Accountable care organizations, or these ACOs, are comprised of a group of doctors, hospitals, and other healthcare providers who come together and are accountable for the quality, cost, and overall care of Medicare beneficiaries within their organization. In thinking about ACO's affordability, the most recent data has shown is mixed on cost savings. Savings have been variable and minimal at best. As you can see here, in 2015, 52% of ACOs saw some savings, however, only 31% showed significant cost savings. However, the cost savings seem to improve the longer that an ACO has been in the program. Thus, as the ACOs are just in their infancy, we will continue to monitor and see if they derive cost savings in the future. When thinking about the quality of ACOs, one thing is clear. They improve quality measures. Each ACO is measured on 33 clinical quality measures, and as you can see here, almost all of these measures improve with time. Thus, although currently it is unclear if ACOs save money, all signs point to improved quality of care with ACOs. The Independence at Home program is a pilot home-based primary care program for Medicare beneficiaries with multiple chronic illnesses that started through the ACA. It started in 2012 and is set to expire in 2017. This act would extend the program to 2019 and expand the number of beneficiaries from 10,000 to 12,000. Thus far, Independence at Home program participants saved Medicare more than $35 million in the 2 performance years that the program has been monitored. That is a $3,000 savings per beneficiary the first year and a $1,000 savings per beneficiary the second year. The Independence at Home program has also shown to improve quality. Over the 2 years that all participating practices have improved quality measures in at least 2 of 6 quality measures that are monitored. The Chronic Care Act also expands payment for telehealth services to Medicare Advantage policyholders, ACOs, and stroke victims, thus improving access. As you can see, by using the Independence at Home program and the Chronic Care Act is able to improve affordability and costs. It continues to be unclear whether the ACOs will improve costs. Although there are no changes in the number of people with insurance, as the Chronic Care Act applies only to Medicare recipients, it does expand access to telehealth services, in addition to expanding access to ACOs and in the Independence at Home program. With the quality metrics improving in ACOs and the Independence at Home programs, there is significant focus on programs that improve the quality of care for our patients with this act. As you can see with the Chronic Care Act, affordability, quality, and access all improve. As you have seen, healthcare is very complicated. We have described how we came to the ACA, what the ACA's impact has been on Oregon, and outlined problems and threats to the ACA. In the coming months, we face a choice: to support the dismantling of the ACA or to support the repair of it. As I have shown you, the AHCA does not improve affordability, access, or quality of care, and by those standards, we cannot support it. The Chronic Care Act does improve affordability, access, and quality. However, it only affects a small proportion of the population. And thus, although it is a good first step, it is only the first and needs to be followed by more significant repairs. As things are changing rapidly in healthcare, we think that it is of the utmost importance that we as physicians stay informed about the options and that we continue to push our representatives to focus on our three central tenets of healthcare: affordability for the system and our patients, access to healthcare for all, and quality of care. If these three core competencies aren't met, then we are moving in the wrong direction. We have all seen each other fight for our patients in the exam rooms and on the wards, but now it's not enough. We must also preserve our patients' health in the political arena as well. Today, we ask that each and every one of you become involved by individually calling, emailing, or writing a letter to your representatives, or by working with the ACP or the OMA to protect our patients. Thank you.